Change our attitudes.
I didn't realize that. Here at the Health Science Center. He's also a staff physician at the VA, and he's a clinical consultant to the Office of Information Technology. And today he is going to talk about drug and alcohol abuse in the elderly. And without further ado,
My apologies. Thank you. It's a pleasure to be with you and to share some of my understanding of my family name.
Beer on alcohol.
In preparation for this, this talk's been revised a couple of times over the last 2 years with the Geriatrics program, so they've got me sort of connected with some of the elderly issues, and I also have the pleasure, I'm going to say pleasure, for the last 10 years of having an elder in the house, my 97-year-old mother-in-law, who up until a little while ago was drinking her 2 6-ounce glasses of alcohol a day. More recently, we're almost in the hospice stage, but I was wanting to share with you a little handbook. The handbook is one of 6 books reviewed by Dr. Lois Brady, because many of us who are getting on in years as faculty have elder parents, and this one, How to Care for Aging Parents, I found probably 20 references to alcohol. Mm-hmm. Alcohol in the elder is something that I guess has been reinforced. There may be some benefits and there may not be. So I'm going to share some observations from my background in nutrition with you today, and a little bit of physiology and a little bit of pharmacology and a little bit of how do we deal with the problems in our cohort of patients over the age of 65. Don't have a whiz-bang version. So these are the issues. When I think the numbers for the elders and the use of medications, I think the VA tops the list. What's the average number of medications for each of your patients when you open up CPRS? 8 to 9.
Average.
I think Megan was very proud of 27 for some of her patients, and that's why the campaign.
What's our polypharmacy rate on LCTC?
Oh, I mean, it's pretty close because they use over 9 meds in this one monitor performance measure. And so the percentage is usually 80 to 90%, but the patients are on more than 9 meds.
Whoa.
I mean, we've got a 6 subset.
Yeah.
And that's why I think the question is a reasonable one, because this is what it's all about, is what is the interaction of alcohol with your prescribed and over-the-counter. Alcohol, sorry, I'm going to have to use this better. Alcohol, does anyone want to give me the exposure rate in our in the greater than 65 population drinking? 50% is the general population. Some people are a little more generous about for the elder, and I don't know if we've got good epidemiology. The article that I found from Michigan, the VA at Michigan, their epidemiology was 15%. But I will certainly present some data for the general population. So we'll try and have a look at some of the highlights, some of the challenges, a little bit of nutrition, a little bit of medications, and the screening approach, for the elder that we might consider. So always when we look at alcohol, as I've already alluded to, there's the benefits and always the risks. And unfortunately, the events precipitate or aggravated by alcohol on the negative side, hypertension, diabetes, the catechism that we have to deal with, and hemorrhagic stroke from epidemiological studies, and obviously impairment of mental status. And with the consequence, altered increased incidence of falls and fractures. And this is considered in those who drink more than what's the threshold for defining alcohol use to abuse in our cohort. And then obviously the spiral that we often see. But these are the scenarios where our attention obviously should be heightened for screening in that group of the population. So certainly there is cardiovascular benefit for both men and women with the drinks, and that's probably why my mother-in-law up until 6 months ago was a successful agent. And then we look on the negative side, obviously the cancer risks are more related to the GI tract. So the fractures is definitely correlated, and bone density is certain.
No, I'm sorry. I went outside the chairs for a second.
Oh,
Did
sorry.
you talk about, when you talk about a drink, do you translate that to so many ounces?
Yeah,
Was
the
that-
nutrition piece will come shortly.
Okay.
Because I come from Australia, and I've also migrated to Texas, and a drink in Australia and Texas is certainly a different concept for different components of the population. You know Foster's, don't you? The can.
Pint, right? Isn't it like it's like quite a few ounces.
26. The drink is 12. So obviously this is the terrifying part, particularly if you're on the freeway on the wrong side.
Yeah.
And we have terrible responsibility as healthcare providers when we sign off on the permissions to go and have that driving test. But that's a big, big risk when age and the habit are combined. And obviously the sequelae for the elders in the trauma units are significant. So unfortunately, even over the age of 80 when we have that, is that the age for annual testing for driving? No.
There is no test.
There's none in California, sorry. I know in Australia it's 80, and I know someone who's 88 and passed the test, and people have chest pain when they're on the road following or nearby. But we have reasons for this because they obviously exceed our teenage cohort that we always would have indicated were the highest ones at risk. So in our population, I certainly believe the relationship for disease is sort of off the radar a little bit because these people have already been pre-selected out of the elder population. They've died from their pancreatic disease and their liver disease and their hepatitis C, alcohol combinations. But the use and abuse are actually fine-tuning areas where we must focus our attention. And while for the general population, I agree with you, it's 50%. For the elder, it may be less, but we've got to have a closer look at that perhaps. So the alcoholics is in the 300 million we have in North America, and the mortality associated with alcoholism is significant. And you can put any number that you want, but in your population, I'm sure those of the elders, there's a significant increased comorbidities once alcohol is added into the patient's habits. If you want to look at the US population over the age of 14, that's where it all goes for consumption data. And this may be 1990 data, but I think that's when we peaked. But that was the average US consumption, so someone exceeds or is doing more than most of our share. it actually probably peaked in 1980 and has subsequently decreased. The alcoholic beverages for, I guess I'm going to say, I don't think water is number one, but it could be, and I don't know what it is now with our bottled water pattern, the number one beverage, but it's tea and coffee are certainly up there 1 and 2, but beer and wine, as far as alcohol consumption, are in the top 10 of all liquid consumed. So, to answer Michael's question, that's what one individual in a 12-month period would be consuming when a standard drink is considered to be a 12-ounce bottle of beer, a 5-ounce glass of wine, and a shot is 1.5 ounces of 80 proof ethanol. So grandma's eyeball or highball or whatever they take it may be 3 ounces, and that's unfortunately when things start to go wrong at the evening hour. So going back to the consumption figures again, having a look at the patterns, obviously there is a gender difference, and 60% of females actually are considered abstainers. I don't have numbers for the elder. And on the other end of the spectrum, for heavy drinkers, which is considered to be greater than 2 drinks a day, 14 drinks per week is about 11% of the male population. I'm not going to do any epidemiological studies in this room for that. But that's basically where our exposure is in the population. I don't have any data for elder. Medical students and the audience that we had last month don't even know who William Shakespeare was. I'm not going to insult the room here. But I did it in high school. And I think if you consider 1620, when William Shakespeare wrote Macbeth, the physiological effects and the behavioral effects were well aware. He was well aware of. I'm going to just quote the terms used in 16th century English. Vasodilation he called nose painting, and does make one sleep, and does produce urine or produce water. I can't remember the words for Shakespeare. So he was pretty good. And then obviously he had in the soliloquy some time on his hands, so he was thinking about sexual behavior, both provokes and unprovokes. And I think by that he meant it increases desire and takes away performance. I think were the words in Macbeth. We actually need to consider the measured numbers in the 21st century and these maybe 20th century data, but realizing that in the elder we've got a significant difference in a major body compartment. Total body water is reduced in the elder, and so it doesn't take much for an elder volume of distribution to get the blood alcohol concentrations that are correlated with the physiological states. So I think it's 80 milligrams per 100 mils is our Texas limit. So all of those euphorias and mild coordination are exaggerated in the elders once they've started to have 1 or 2 drinks. And I think it doesn't take much for an elder to get the 80 milligrams per deciliter with 1 to 2 drinks with all the above and the increased consequences that we've already discussed. So I'm going to quickly review, I'm going to call it medical school pharmacology and a little bit of physiology. And this is the data that I have available to me for the pathways for alcohol metabolism. And most of us, on average, and I believe this data probably does come from medical students. They were good volunteers when this data was gathered. Can clear 0.1 grams per kilogram per hour of which 90% is hepatically metabolized in the 3 enzyme systems described above, of which the mitochondrial ethanol oxidizing system is the inducible system. And this is the important one for our patients to realize. And then obviously in excretion, the basis for blood and alcohol testing, we have the 10% excretion. The energetics represent about 7 kilograms per gram per day, and that term empty, does anyone with any nutrition background want to tell me what's empty about alcohol?
No nutrition. No nutritional value.
No vitamins, no
No.
minerals,
Nutrients.
although it was seriously debated in the early 80s to fortify folic acid.
Oh, really?
Oh yes.
Drink when you're pregnant.
Beer's been around for a long time, but it has always been without folic acid. And so you can see the capacity that some people can get up to in clearing on a daily basis about 1,200 calories of alcohol. There are some who that may be the total source of I'm going to say empty nutrition. So it doesn't take long, as we'll see shortly, to become deplete of nutrient stores. To focus a little bit on the pharmacology, realizing this is the first pass in the short-term exposure. Both on the right there is the stomach, where we have a degradation pathway to acetaldehyde, and then in the hepatocyte, in the first pass, we have the 3 systems that I alluded to before, which are cleared. And these, the most common one, shared pathways for many of the prescribed pharmacological agents that constitute polypharmacy in our population. With long-term exposure, these are the inducible systems, both perhaps increasing metabolites that may be toxic for the effects that we're aware of, and further the impact on the shared pathways. And metabolically, these are the functions that we see in the acute setting, but also in the acute setting for the elder, with the pathways that we're all familiar with for producing the profiles that we may see on screening, the elevated uric acids, the elevated lactic acids, secondary hyperuricemia, and sometimes in our population something we need to be aware of is the hyperglycemia, and then obviously the hypertriglyceridemia and the hepatic changes that we would see in this group of population that we're all familiar with. So quickly from the effects on the patient's nutritional status, we've looked at the energetics and the capacity, but as I alluded to already, the impact on nutrition, you've got to consider that impact. Some people's total intake may just be ethanol. Further, we would see the impact on regular food intake and alterations of the, I'm going to call it processing, digestion, absorption, transport, metabolism, and obviously storage. And these are the impacts that lead to the commonest deficiencies that we would see in the alcohol. The alcoholic, not necessarily the alcohol user or the alcoholic abuser, but we certainly need to be aware of when we see the malnourished patient. Tash Hoyampa here in our department studied in the rat the major water and fat-soluble micronutrients and looked that we see across the right of the most commonest deficiencies seen in the alcoholic folic acid. B6, the cofactor for processing many of the amino acids, and after the degradation of many of the amino acids. Vitamin B1 and its significant role in neurological function, and then obviously vitamin A in the integrity of the epithelial cell. So these are the areas that are certainly major nutrient deficiencies, all of which in folic acid are impaired when we consider absorption, storage, metabolism, and excretion. Vitamin B6 predominantly storage, metabolism, that's excretion, thiamine, and vitamin A. So we certainly have a major interface, and this may be a contributing factor for some of the diseases that we've seen, depending on what organ system we're looked at.
What about vitamin D?
Vitamin D, Tash didn't study, and I'm not 100% sure. I haven't looked at personally at the relationships with vitamin D. Is anyone aware? I indicated up front that there's decreased bone mineralization, so I'm sure there's a process.
Well, I mean, in our experience in some of the patient population here, surely vitamin D insufficiency or deficiency with frank osteomalacia is not uncommon, but I don't know that it's going to be common in the elderly population. Of course, most of the facts in the elderly population are somewhat open for speculation at this point anyway. But I think you have to be a pretty long-term heavy alcoholic to see
Right.
the calcium, phosphorus, and vitamin D levels and osteopenic pictures on bone films that are characteristic of osteomalacia, but it's common in that population.
Are you saying that alcohol exposure mediates the association between alcoholism and those vitamin deficiencies, or is it mediated through just nutritional deficiency?
Specifically, I was indicating the mechanisms, the deficiencies are associated in a percentage of the alcoholics or
Right.
alcoholism.
That doesn't mean it's the alcohol doing it. It may be the lifestyle of certain alcoholics that does that.
But at the level that's been studied in the rat, and that's as far as it's ever gone, has been in those various pathways.
I think in the case of vitamin D, for example, it's a decreased total nutrition intake.
And that's usually where the studies end. But reduced intake plus impairment of those pathways and things go down. Have we got to finish at 1?
I think we have a few minutes.
Okay. So I think these are the numbers just from the epidemiology, and obviously depending where we receive our patients, the reasons for hospitalization may be associated with alcohol consumption in the elder. I can't remember the source of this, is now increasing reasons for hospitalization for all of the associated complications of alcohol, whether it be falls and fractures, so it's pretty general. I was up in the cardiology department yesterday, and I think everyone was cheering on with Dr. Stephen Bailey, who said cancer is now the #1 killer in North America, not coronary artery disease. They believe that cured coronary artery disease, that's primary prevention, but that may be another reason for this statistic as well. So, in the elder, I've alluded to the fact that there's certainly less consumption 15 to 50, but also in those that survive, there is the stable cohort, as well as there may be in those transitional states that we're all familiar with in the elder, the late onset of alcoholism, which is where it gets to the definition and the diagnosis. And obviously, I've alluded, or this is just to summarize, that there will be decreased tolerance, and it's predominantly associated with the volume of distribution and obviously the concentration. And these are the problems that we all need to evaluate and increase our ability to screen for alcohol in this scenario. So for screening and assessment, what are the questions to ask? And we've alluded to what is a drink. And then we also could ask these questions, the amount and the frequency. And there are many sneaky ways that each of us in our clinical experience have determined how we broach this subject. Probably the best way is to talk to a family member. But I think when a patient acknowledges that they are drinking, then you just challenge them. And the most sensitive question is, what's the most you've drunk in the last 3 months? And they'll tell you at a setting, and you get a pretty idea. But the quantitative actually is an important issue to deal with, and we're all familiar with the cage issues and the sensitivity of the various studies for identifying risk in the elder with the tools that we have available. We're online using the audit, but in our population, what do we use in the geriatrics clinics here? Do we use which tools do we use?
We use the cage questionnaire.
Cage. Online now we've got the audit, and I think studies are looking at the S-must.
Bill, for the trainees, do you want to go back to the cage and just
sorry.
flash it up a little bit?
Okay. This came out of Michigan, and these are the 4 questions that I think each of us are all familiar with. And any one or 2 or more of these positive mean that we've got to get greater exploration of the patterns and follow up on. The cut down and drinking is certainly things that you can do in the clinic, you can do online before the patient comes to the clinic. But these are one of the very basic clinical tools that we can use, if not before interaction with the patient, also when we're in their presence. Did you want to?
No, I
Just, yeah. It's important to do the 4, and I think the threshold is 2 or more than you've got to explore further. And then obviously, once you've identified the behavior, then with screening and have positive screening, then the question is, what do you do? Because not everyone is ready for change, and what are the opportunities? And as I shared with you, all the references are here for the manual for before the healthcare setting, which are basic healthy living issues for both the well elder and for the, I'm going to say, the frail elder. And basically all the issues that you can do just by one-on-one sort of prompting and support and setting up the mechanisms. I've identified that it's not just the healthcare provider, but it's the whole support network that you have to work with there. The process for NIAAA, and this is a reference for all physicians. We reproduced it in June for the handout. It's an online manual by NIAAA, and this is just alluded to here. You can download it, or we can post it on the resource. Is truly some interventions that have come out of NIAAA on helping patients who drink too much if our screening is positive. And it's a clinician's guide and provides resources available to you. And I think that's an important approach, so it addresses both the screening and also the interventions. And with these processes, it's really important to then come up with a plan for appropriate interventions and how are we going to follow through. So I was going to really just stop there because we have a challenge, but the most important thing is screening and look at our polypharmacy and be aware of our degradative pathways for most of our profiles when we give our medications to our patients. And with that, really incorporate that into the care plan of the elder. I think we are not very good at necessarily identifying the typical of what's under the water, and we have a big challenge. And I believe the problems that we're all exposed to certainly has highlighted the need to become aware and adept in using the screening tools. I'll stop there just because of time, and I apologize for so quickly rushing through and being. No. Always we get the tip-off with the gamma GT in our metabolic profile, or the isolated hyperuricemia, or the isolated hyperlipidemia, but we should know our patients better. And it's not our patients' comorbidities and profiles where we suspect it. It's working with the family member to confirm our suspicions. But I don't believe there are any good tip-offs. I always look at the MCV,
Okay.
and that's a lab profile that I always use, and greater than 100 I start being a little suspicious. The best MCV I saw was on an inpatient here, and that was 128. And it was the dietitian who sort of got everyone excited because she took a dietary history, and that comes back to Dr. Roy's question. That guy had New Braunfels, his only calorie source was the back door of McDonald's, so he got carbohydrate bun and the meat patty and no micronutrients, and he got, obviously, ethanol. It was a cure. His folate deficiency reversed. But yeah, it's just the routine profiles that we have available to us, and those of us who keep thinking of alcohol just take that question for granted, and I apologize because it's routine labs, uric acid, sometimes the gamma GT and the triglyceride are usually my tip-offs, and sometimes we don't always get the uric acid. Yes, ma'am.
At what point would you say behavioral therapy doesn't work? Would you start them on pharmacotherapy or?
That's in part in this guide. So I'd strongly recommend each of you download. And they've basically got some recommendations when you would certainly consider an pharmacological intervention. But I'm really just talking about the middle of the road, 1 to 2 drinks, 3 to 4 drinks. And behavioral therapy, from what I just briefly summarized, it's the support mechanisms that would help the elder. And those are certainly behavioral skills that you and I as internists don't necessarily have, so that's why we have healthcare teams to follow through on identifying first the problem. I haven't analyzed or studied the cutoff when you go from failed behavioral therapy to pharmacological intervention, but we certainly have colleagues in our team that would push those types of interventions.
I have a question.
Yes, Bob?
If you look at, this would be looking more at the population of people who probably, who qualify as alcoholics, but who aren't the people who, aren't the fifth a day type. I mean, people who are, situationally heavy drinkers or moderate drinkers who then, have you seen anything out there, especially I think recently, on aging, grief, depression, alcohol use, and especially, the question is, as people go through, especially grief and progressive social isolation, especially older elders, who are still, who still may be living at home and everything. Any data on what they do? How many percentage of them will go from some kind of moderate drinking to more problematic, heavier drinking? I mean, the intake is stable, but my observationally, if you look longitudinally for 20 years at some of these people, I'm thinking of some of my, I've got some, fortunately I'm adopted because I've got some pretty strong alcoholism genes running through my family. But if I look at these people who live to their 80s and 90s, and I mean, they go through periods of time where, they're with grief and some, either depression or just simple grief. I've seen their alcohol use just become dysfunctional, starting to have falls and bleeds and other events. Any data on that? And then also, I guess, a secondary question, which maybe Dr. Royal can also add in. Has anybody looked at the natural history of people, not people in whom, not the people in whom they have, who take in tremendous amounts of alcohol, where you're really not going to be able to notice all this stuff, but as people get non-alcoholic dementia setting in, what happens to their drinking behavior in that early period of time before they start needing other people to get their alcohol, or they live in an institutional facility? Any numbers or any observational stuff on that? Or, and then of course anything that's been done to intervene, which I've seen absolutely nothing on.
I'll tell you one thing, I've been struck by how people who just couldn't possibly go to the store and buy a six-pack of beer are still drinking heavily, and you interrogate the family and you find out that they're doing it all for him because he'd get mad if I didn't do this, and yet the guy is just so terribly demented that it's just how could he even sustain a drinking regime, But it's my impression that alcoholism actually is not so common in 80-year-olds that we see. We see people with cognitive impairment, but it's just not really an issue. And I've also anecdotally been impressed by some people who are drinking, persistently into 100 years old, sitting there and he says, well, I just have my beer every day, And there's a paper you might look at recently where they looked at the CNS substrates of people who abandoned smoking just like that after years and years and years, and then suddenly they abandoned smoking, and they associated that with strokes in the insula, which is a part of the cortex that mediates between autonomic function, somatic inputs, and emotions. So you might imagine that the insula would be somewhere where cravings take place. And so a lot of the drug addiction literature really was impressed by that because they were thinking of drug addiction as being sustained through reward systems, dopaminergically mediated reward systems. But now they're starting to look at the insula. Well, the insula is specifically targeted by Alzheimer's disease and Lewy body at preclinical stages in their evolution. So there are probably 40% of non-demented 70-year-olds have insular neurodegenerative brain disease already. And that might provide a mechanism for explaining declining alcohol use in formerly abusing persons in younger life who just sort of grow out of it, because the wave of the tangles has gone by the insula and taken away, one of the big motivations for drinking at that level. So that'd be kind of an interesting thing. See if you could look at insular atrophy rates as a mediator of successful weaning away from previous alcoholism.
On drug and alcohol.
I mean, I've seen that observationally.
Yeah, people just one day don't need anymore. They used to drink and fit the day, and not the less.
And you wonder, and you just wonder, I always wonder, did somebody just have something, did somebody just have some kind of harbinger of something bad's going to happen to them, and then they just,
Right. Well, stopping smoking is usually pretty ominous. I mean, it's like 6 months later they have a lung tumor. And but it turns out that insular infarcts can take that away from you, just like that.
So
Stroke is a cure?
Yeah. Well, I mean, it just points to the role that structure plays in mediating these sorts of behaviors. The other thing, the whole idea of alcoholic dementia is also pretty controversial even now, and it's just hard to get the models to show associations between heavy drinking and cognition. And I just reviewed a paper for JAGs. I rejected it because they were jumping up and down because they found a significant association between lifelong alcohol exposure over 30 years and mild cognitive impairment. And so the highest quartile of the alcohol exposure was associated with MCI, and they were saying, see, this could be a harbinger of future dementia. And so I just took the actual exposure rate and calculated it backwards, and it was 8 drinks a day for 30 years. So
Whoa.
if you average 8 drinks a day for 30 years, you might get MCI at a higher rate than expected.
If you
So I personally think that we all know heavy drinkers who are terribly cognitively impaired, but I suspect it comes from living the lifestyle of a heavy drinker, and it's not actually the alcohol. It's either intoxication acutely, or it's nutritional deficiency, or it's getting beat on the head at bars a couple too many times, or it's the motorcycle wreck you had 10 years ago.
Right.
It's not.
Or the other drugs.
Right.
After working in drug and alcohol,
Yeah.
what you're finding is most people are now pure alcoholics.
Yeah.
They're taking other things, and that really
Right.
exacerbates whatever they're else. It's not that they're just.
But I don't have any data on late onset alcoholics, but it's certainly and I sort of summarized it, when there is a stress, this is something they revert back to for whatever reason, and that's when they're at risk, and that's actually when we need to screen perhaps to see what's going on with that.
Like I said, maybe the subset of population that doesn't have a real physiologic addictive, people who may not necessarily pass the Cage questionnaire all the way, but people who have, what I've seen in people is people who have social networks that control their drinking, and keep it down a little bit, and then once those social networks go away, I've seen people start to have. Now, is it that they've got no one to watch over them when they are drinking, or they're drinking more? I don't know. Or is it just that we as healthcare professionals will pick up on the dysfunction of the alcoholism, whereas previously we would just say this guy is a heavy social drinker, but there's no problem here. Well, that's certainly something to pursue.
Is there another question? Comment?
Besides the Alcoholic Anonymous, there is a need of resources for people either in the VA or outside the VA? Do we have a program inside the VA for?
We certainly have our unit downstairs. I'm not quite sure what percentage they take from the geriatric program for our substance. I honestly don't know. But the VA certainly has substance abuse centers. We have strong focus in both psychiatry and psychology services to offer consultation and resources. But Alcoholics Anonymous is certainly the 12-step model that no one wants to find anything better.
This rational recovery is another one.
Because one of my patients was complaining that he was asked money after 2 sessions. So he
No.
left. He left the group.
They pass it, it's donations.
Okay.
Yeah. There's another one I can send you on rational
Thank you.
recovery that never got too much leeway, at least in the West, but it is one that is used. And that's the idea that you can somehow, and again, this is very controversial, it's used in other places outside this country, where you control drinking. It was for a while, very popular back east. Coming out, I think some people have done some work on it. It's called rational recovery. It's another model. AA didn't like it.
Wonder why.
Well, yeah, I wonder why.
Any other questions? Okay. Sorry, it's late. This is just a commentary with some review articles. Again, NIAAA has got a lot of resources available to us. I would strongly recommend you just go to the NIH and have a look at NIAAA. You'll see what is current in as far as research is concerned.